Well, good afternoon and welcome to the 653rd meeting of the Economic Club in New York. I'm John Williams, I'm the chair of the club, and I'm president and CEO of the Federal Reserve Bank of New York. It's an honor to be here with you in this milestone year, the 115th anniversary of the Economic Club. The Economic Club in New York is the nation's leading nonpartisan forum for discussions on economic, social, and political issues. And a special welcome to members of the club's 2022 class of fellows, a select group of diverse, rising next-gen business thought leaders, as well as grad students from NYU Stern School of Business and Rutgers University. Now, I'm honored to welcome our guest today, Dr. Rochelle Walensky. Rochelle is the director of the Centers for Disease Control and Prevention and the administrator of the Agency for Toxic Substances and Disease Registry. She's an influential scholar whose pioneering research has helped advance the national and global response to HIV/AIDS. She's also a well-respected expert on the value of testing and treatment of deadly diseases. Rochelle served as chief of the Division of Infectious Diseases at Massachusetts General Hospital from 2017 to 2020, and professor of medicine at Harvard Medical School from 2012 to 2020. She served on the front line of the COVID-19 pandemic and conducted research on vaccine delivery and strategies to reach underserved communities. She's past chair of the Office of AIDS Research Advisory Council at the National Institutes of Health, chair-elect of the HIV Medical Association, and previously served as the advisor to both the World Health Organization and the Joint United Nations Program on HIV/AIDS. The format today will be a conversation, and we're fortunate to have club trustee and president and CEO of Memorial Sloan Kettering Cancer Center, Craig Thompson, as our moderator. Now we'll end promptly at 12:45, and any questions that you submitted to the club were shared and may be addressed during their conversation. In addition, we'll be using the chat box for this conversation, and you can enter questions directly in the chat box for their consideration. As a reminder, this conversation is on the record as we have media on the line. So Craig, if you're ready, I'll pass the microphone to you.
Well, Rochelle, I want to join John and welcome you here to this. As he said, you've been a physician and scientist for your entire career, a world leader in infectious disease modeling and understanding, work at HIV/AIDS. You were leader of the infectious disease program at Mass General during the first year of the pandemic. Many of us enjoyed the amazing expert opinions that you shared on multiple media outlets in the first year as we came to know about this COVID pandemic. What possessed you to decide to take up President Biden's offer to become the CDC director?
I'm so delighted to be here. Thank you so much, Craig. I was never expecting the phone call that I got. This was not a job I applied for. This was not even a job I aspired to, although of course it's such an aspirational position. I received a phone call in late November and was asked if this was a position that I would consider. And of course, there was so much work. We were still knee deep in the work that we were doing at Mass General. There was so much work yet to be done. And clearly everybody knew the pandemic was not over. This was just as we were starting into what was going to be the alpha wave. But I received this phone call and said, could you help? And what I said at my nomination speech and remains true is it felt like your code beeper as a House officer was going off and somebody said, you need to run to the code. And so I didn't really feel like, I certainly felt like this was some place I thought I could help, someplace I had expertise. And so if somebody was calling on me to assist, I felt like this was something I should and wanted to do.
Well, we're, as a country, very happy that you responded to the code. As you mentioned, since your appointment did not require a Senate confirmation, you hit the deck running in January of last year and been in the job now about 14, 15 months. You've had to handle three major waves of COVID. The alpha wave, as you just mentioned, the delta wave, and most recently, Omicron. For most of the public, we don't really understand how these different waves come about and why they get different designations. New Yorkers today woke up hearing that there are two new subvariants of Omicron. Can you tell us how the CDC learns about these new variants and how you track them to understand its spread and its impact?
Sure. Well, I'll tell you, we don't always learn about them in the same ways each time. Certainly we're speaking with our international colleagues all the time, trying to understand what is happening in the international setting. Sometimes these variants emerge, these sublineages emerge. As you heard from New York, they emerge from here. They're somewhat homegrown, although those two sublineages we have known about. There is a database of all of the variants that are out there, and we monitor that carefully through GISAID. It's an international database. With Omicron specifically, I saw it on Twitter on Thanksgiving morning. I had seen there may be a new variant out there. Sometimes you have to take that with a grain of salt. There are a lot of new variants that are emerging all the time, and what are clinically meaningful and what are not are for us to sort of work through with our international colleagues and decide. But I had started to hear buzz about this early on Thanksgiving morning, and by that afternoon, in fact, literally as the turkey was coming out of the oven, my phone was going off and said, we really need to talk about this. Partially because of data that was starting to emerge from our colleagues in South Africa, and maybe just a plug for the incredible work of our South African colleagues. First of all, the gift of science, and that is that these are colleagues that I have previously worked with in the HIV/AIDS world, and so science really coming together, having a phone call, having a conversation, a Zoom call, sharing our data that evening, Thanksgiving evening, to understand what they were seeing, to understand what we might be in for, and to really start planning. And we had numerous conversations over the ensuing weeks about it.
And so now we see that there are these new variants coming on, and that's, as we've learned from the public side, is that RNA viruses, which COVID is part of, are highly susceptible to mutations. When and how does the CDC start to think about paying attention to one variant over, as you said, many that are reported in the literature?
Yeah, so when we think about what a new variant might be or a new sublineages, so interestingly, through Omicron, we're talking more about sublineages. What is BA1? What is BA2? We've heard a bit about BA4 and 5 that they're seeing in South Africa, or this BA 2.12 and 2.121 that have just recently been reported in New York. Those are all sublineages of the parent Omicron, the initial ancestral strain of Omicron. What I think we really need to do each time we hear about these is understand sort of two groups of kinds of information. What is the inherent things that are inherent to the lineage or the variant itself, and what is how it impacts our countermeasures, or how our countermeasures are impacted by the variant itself. So, for example, we need to understand, is the variant more transmissible? Is the variant more severe? Those are questions related to the virus. And then, does the variant evade a test? Does it evade our vaccines? And does it evade our therapeutics, our monoclonal antibodies, our antivirals? So as we think about those two buckets, we start to understand what's the science that we need to do against these variants to really understand that. When we start seeing variants that are out-competing other variants, and that's a little bit of what we've been seeing now with this BA2.12 in upstate New York, central New York, it may very well be because it is more transmissible. So an inherent characteristic of the virus that allows it to be more transmissible. And if it's more transmissible, it may outcompete other things that are circulating.
Well, Omicron's the first of the waves that really happened when a majority of the population, certainly not all, but a majority of the population has had access to a vaccine. So the vaccine may be shaping some of this as well. So how do you determine whether or not the increased infectivity is because the virus has a native ability to infect more people, or that it's just become resistant to our control measures, such as the vaccines?
So I'm so glad you asked that question, because it demonstrates the inherent challenges of doing these studies in the backdrop of a population now that has a very diverse history of disease that they've seen, time that they've seen it, variants that they've been exposed to, vaccines, and how many they've had. And so when we embark on these studies, and I'll put a plug in for our Center for Forecasting and Analytics, our new center here at the CDC, we say, okay, who can actually help us conduct these studies? After Omicron, we looked for collaborations. I found one at Kaiser Permanente, Southern California, that had a closed enough system that they could look at prior history of disease, prior history of vaccination and when, comorbidities, and control for all of those factors as they looked at disease severity with Omicron specifically. When they were able to do that, and we did that actually rather quickly within the first several weeks of having the virus here, we were able to demonstrate that symptomatic hospitalization of Omicron versus Delta was down about 40%. ICU visits were down about 50%, and overall mortality was down about 80%, controlling for all of those factors with Omicron compared to Delta. So we knew we were dealing with an inherently, albeit more transmissible, less severe virus.
So that's an important point that I think probably needs to be brought home to the public. There's a difference between the virus becoming more infectious, more likely to pass from one person to another during the infectivity period, versus becoming more pathogenic, causing more severe illness or illnesses that can lead to more harmful side effects and consequences for the host. How do you determine that?
So we do a lot of household studies. These are really hard to conduct, but we also can tell based on, certainly we can tell by gene mutations. So some mutations bind to a receptor more tightly, and that implies some increased transmissibility. So we can do it by specific mutations. We can do it by household studies. Those are harder to do, as you can imagine. But so the other thing I think should be noted here, first of all, is how hard those studies are to do, but also that oftentimes viruses evolve to be both more transmissible and less severe. So from a virus's standpoint, killing the host doesn't lead to more viral transmission. And so the virus survives when it is able to transmit more readily and to transmit to more people. And so from the viral perspective, having the host not be able to transmit, i.e. incapacitating them, putting in the hospital, is not advantageous. So it's not really surprising. It doesn't necessarily mean that will happen all the time, but it's not that surprising that that has been how this has evolved.
So you're right. The science that we're taught in medical school is that, in fact, as viruses evolve, they become less pathogenic because they want to keep their host alive to spread to the next host because they can't maintain themselves independently of a host. That's been a concern going forward. Would any of these mutations lead to a much more pathogenic? We saw in the early waves, the first wave, that there was much more severe pulmonary disease. Patients got very severe pneumonias that we're not seeing right now, which fits what you just talked about. What's the likelihood that it's going to become more pathogenic?
Well, so we don't know. Certainly it could be that we have a new strain altogether that is more pathogenic and more severe. That would be more pathogenic and more transmissible. That would be something that would be worrisome. Another thing that would be worrisome, of course, would be its ability to evade our immunity. So maybe if we can back up just a bit to talk about the Omicron variant here, less pathogenic, as you noted, more transmissible, as you noted, but also more able to evade our vaccine protection. And that has been one of the real challenges with Omicron. If we can map through the different waves with our wild type virus and our alpha virus that we initially had, our vaccines actually worked quite well against any infection. They worked quite well against severe disease and quite well against death. Then we got to the Delta variant. It worked pretty well against infection, although you were able to transmit if you got infected. And so that was new with Delta. And then, of course, with Omicron, we have seen that you really do need more immune protection against Omicron compared to both prior waves and also, in terms of protection. So we know vaccination now against Omicron, even if you're boosted, may protect you against infection, but really protects you against severe disease and death. And so, our benchmarks have had to change a little bit. Our expectations of what the vaccine can do or should be able to do have changed a little bit as these variants have emerged.
So this is a plug for, obviously, for booster shots, that we need to get rid of the severity of the illness and turn this into maybe a common cold. We need everyone to get those booster shots. How do we convince people to take more doses, to get those additional boosters?
Yeah, it wasn't intended to be a shameless plug for blue boosters, but it is truly the case that we have seen through these variants that you need more immune protection. So for example, 2 doses against Omicron really protects you about 28% against infection, 3 doses, 65%. So in terms of what we need to do in terms of convincing people, we have quite a few people out there who have gotten their primary series who haven't gotten their booster. And so in my mind, that is a population that is amenable to vaccination, but hasn't really understood the importance of that 3rd shot in the context of Omicron. We know things like the 3rd shot against hospitalization protects you, 88% if you've gotten your 3rd shot, but 54% if you've only gotten 2. So, I get often asked the question, how do you convince people? But I think at this point, we have to spend some time listening and not talking, because we have convinced those people easily. That there were many people who rolled up their sleeves and were waiting in line. But the people now, we really need to understand what their hesitancies are. And they are diverse. They are, I can't take the day off of work. I don't know how to get it. I have never signed up. I don't have a mobile device. Or, I thought 2 would work and now you want 3 and I just can't keep going back. Or I had side effects from the first one. What's the information that people need to be empowered with so that they can take control of the situation and understand the importance of this shot?
Well, that's a good point that you're bringing up. Now, the CDC is responsible for monitoring vaccine safety. So how do you decide when another shot is enough, or that it's safe to give a next booster or a next shot? How does that monitor?
So I should mention that we have this incredibly robust vaccine safety system where we collect data from many different venues. So one is our vaccine adverse event reporting system. This is a passive system where people report to us any side effect after getting the vaccine, where they, and certainly we want any severe event. And we adjudicate all of them. We go to the chart and we review all of them when we get those reports. Now, certainly any severe event like a hospitalization could be related to the vaccine or could not be related to the vaccine, but that's a passive way where we collect a whole bunch of information and then go back and adjudicate at the chart level. We also do a reporting called VSafe, and this is new through this in this pandemic, and that is active reporting. Tens of millions of people have received VSafe electronic requests where we say, how are your symptoms after your vaccine? And we get that information from VSafe. We also have used VSafe to monitor vaccine safety in pregnancy. So we do ask the question, are you pregnant? And then we have tens of thousands of pregnant women now that we have been able to not only follow when they've said, yes, I am pregnant, but then we call them after their baby is born, and we call them 3 months after the baby is born. So we can really understand the safety to mom and to baby, and potentially the protection of baby as well. We have clinical academic colleagues across the country who we also partner with through clinical and immunization systems to understand both a concrete numerator and concrete denominator. So a really robust, the largest we've ever had in our history of vaccine safety. That is also, so as we do that, we understand how our vaccines are doing, and we frequently report on that. We also have to report on vaccine waning. How long are our vaccines working? And we use a robust network there as well. We have numerous cohorts of studies across the country. But one of the things that's proved really helpful in this situation is these multi-jurisdictional studies where we go to jurisdictions. In fact, New York was the first, and they are able to partner their immunization data with their testing data and their death registry. And with that, we can see how our vaccines are working, both in terms of breakthrough infections and preventing mortality.
Well, at some point, each of these variants is trying to evade the immune system. At what point do we have to decide we need a new vaccine rather than a booster of the existing one? It's a trade-off of safety versus getting ahead of the virus and where it is going as it evolves. How does that get decided?
Those conversations are actually happening right now. There was an FDA VRBPAC meeting last week, I believe, and CDC will be having these discussions on how we will start to make those decisions with regard to protection, not just against a new variant or a new sublineage like we've had with Omicron, but how can we anticipate what a new novel variant, the next Greek letter, might look like, and how can we be best prepared for that? There is a sort of general feeling that respiratory viruses thrive in the fall and winter season. So if we were to anticipate when we might have a new variant emerge or a new surge of cases, what does the fall and winter look like? And how do we prepare our vaccines to be best, to provide us the best protection come the fall?
Well, the most historically significant respiratory vaccine or respiratory virus is influenza. It's been with us for thousands of years. And yet we need a new shot every year and we get it in the fall. Will we evolve something like that for COVID?
We certainly are having conversations of what a fall vaccine would look like. And it's interesting because if people have been somewhat frustrated by, well, you mean I need another shot? I think they generally forget childhood immunizations. For example, polio is a 4-shot series, and we have almost no vaccines that are a single shot series. So we do need to remind folks that many of our protective series require more than 1, 2, or 3 shots. We are looking at a fall vaccine and what it would mean for a fall vaccine. I don't think we yet know what the optimal COVID protection vaccine will be years from now, but it may very well be something that evolves like flu, where we have a flu and COVID vaccine. Certainly there are discussions about whether they could be co-administered and other things, but I think that this is going to be the subject of much more emerging science.
Well, there are other common coronaviruses that we've called the common cold for all of our lives. And we've never developed vaccines that were against those that were effective and stable. What is there any knowledge to be gained from that, or is really COVID an entirely new virus and its ability to elicit an immune response?
Right. And so certainly there's science emerging now on pan coronavirus vaccines. Could one vaccine actually not only take care of COVID, but of all of those nuisance common colds as well? And there's also speculation that maybe one of these coronaviruses that has emerged to be a nuisance, mild disease, pretty transmissible disease, was actually a pandemic in hundreds of years past, and that has emerged to be one of these sort of surges in the winter, mild disease, as transmissible viruses do. They lead to mild disease, and has sort of evolved, and maybe years from now that will be the fate of COVID. We don't yet know that. I do think if we don't have any new surprise variant, that ultimately what may happen is we will continue to have surges, but they might have less amplitude, fewer cases, and fewer severity of each amplitude. So
I was surprised to learn from actually many of my medical colleagues during the Omicron surge over the new year that many of them still expected, and this isn't the infectious disease experts, but physicians and nurses who are caring for patients, that they still imagined, just like SARS-CoV-1, that we would eliminate the virus completely from the earth by this vaccination strategy. That's been countered by the various arguments that this is already at what's called endemic levels, that the virus is circulating throughout the world in a way that it will not be eradicated. What's the CDC or your personal position on whether this will ever be an eradicated virus, as we've seen other viruses get eradicated, or it's going to be endemic and be back with us every fall and winter, as you said?
So I might even go in between those two and or ors. I think we're with this coronavirus for the long term, but I don't yet think we're at an endemic state. So endemic in my mind, from even a pure epidemiological standpoint, is that you've reached some steady state. And in fact, being endemic and having a high amount of steady state, is being in a high level of disease, a high steady state, is not necessarily a good thing. So we want to be endemic, but we want to be endemic at a low level. I would argue we want to be endemic, but not at 500 deaths a day, which is where we still are, even though our cases are low. So I do think that we will be living with this coronavirus. I think that I'm certainly hopeful that we can get to a place where it doesn't lead to continued severe disease, and that as a result of both viral changes, viral mutations, and viral variants, as well as our medical countermeasures, that we can coexist with this at a rate that doesn't have that lethality. But I don't think we're there yet, because I really don't think that we know when another surge will happen.
So one of the questions has been, because different nations have taken this on in different ways, countries like China and Korea really locked down their economies completely to try and keep COVID out. Now, one advantage that they tout that was advantageous before Omicron was that, in fact, they were able to keep their economies going. They were able to keep their people safe. And now that they're experiencing the Omicron wave, it's a less severe virus than the initial virus, even the Alpha and Delta variants. And so that they did that temporary protection to get to what you'd say would be a low-level chronic infection. What does that tell us about protective measures for our own country as we go forward?
Yeah, I think this will be one of the important lessons that we have to learn and understand over time. One could also argue that, we had enough time over the last year to do a lot of vaccination before we had an Omicron surge, and that the reason that we have seen with Omicron, I think we talked about this, what I call a decoupling of outcomes. We had a lot of cases and much less severe disease. And because of that, or I would say the reason for that is not just that Omicron was a less severe virus, but also because we had a lot of vaccination that had happened in the meantime, and a lot of boosting that had happened in the meantime. So I think the backdrop of our population that has seen a lot of disease before and has some infection-induced immunity, that has seen a lot of vaccine already, is really what helped protect us against this Omicron surge.
So how much does natural immunity of those that have had Omicron, say, contribute to this getting to a low level of endemic infection? What's your thoughts on that?
So it is among the reasons that we rolled out a different set of metrics at the end of February. And that is, we have seen through antibody studies that about 95% of the population has some antibody level from either infection or vaccination. The interesting piece of that is we don't yet really know or understand how protective that pure antibody level is. We don't have any quantitative correlate for you have antibody and therefore you will or won't get sick should you see the next variant. And now we have this really fascinating backdrop in this country, a very diverse backdrop of populations that have seen wild type Alpha, Delta, or Omicron, populations that have been vaccinated, and then waning of that protection, whatever protection that is. And so that's, I think, going to be among the holy grails to understand how that backdrop is going to translate into protection. What we know about Omicron, and this is really in work that's starting to emerge, is we do think early on Omicron BA.1 protects you probably quite well from BA.2. We haven't seen a lot of reinfection in the short term. That protection is even better if you have had a vaccine and have had Omicron. But if you've just had Omicron, there is concern that you have a relatively short period of protection, but that you may be susceptible again in the longer term.
So that gets to questions that people are really getting sick of all the measures we've taken to protect ourselves over these 2 years. We've seen the population trying to get out to do things, get back to normal, whatever that means going forward. You're responsible in the CDC for travelers' health as well. So you've had to recommend, and just did this last day, recommend we'll continue to wear masks on the trains and the planes. Tell us about that decision, and what are you going to do about the travel on cruise ships and other things as we go forward and opening up?
So we will see. I'm not going to break news here, but
okay, fair enough.
part of that is because we're following the data carefully. The decision yesterday, I think, was an important one in the context of where we are. First, really good to see hospitalizations are coming down, deaths are coming down, still around 500 a day, still well higher than we want to be in terms of deaths, but at some pretty low numbers compared to where we have been previously in the pandemic. At the same time, over the last, 8 days, 10 days, really since early April, we have seen a rise in cases across the country. Over half of our jurisdictions have seen a rise in cases. So while we have quite a bit of good news on the hospitalizations and deaths trajectories, our case trajectories are actually going in the other direction. And so what we wanted was a little bit more time to understand whether these case trajectories are going to also lead to more hospitalizations. We're watching that very carefully to make sure that it's one thing if we have cases, it's another thing if those cases lead to severe disease and hospitalization. It is among the reasons that we launched these COVID-19 community metrics at the end of February, this change of our metrics. We saw with Omicron a much more mild variant. Many people were presenting with mildly symptomatic, no symptoms with Omicron. And we really wanted to shift our metrics to understanding severe disease, medically significant disease.
Great. And I think given that yesterday's decision was about masks, I'd like you to comment on masks. Now, there was a lot of confusion early on about whether masks were protective. I think we have very clear evidence that masks are protective. I think we know that influenza, for example, has disappeared in the last 2 winters, at least here in New York. We never even declared a flu season because as we remasked for Omicron, the rising cases of influenza we usually see every winter just went away in a 2-week period. Where do you see the role of masks in preventing not only COVID infection, but other respiratory viruses as we move forward as a society? We used to look at other countries and say, oh, that's ridiculous that they do that. But I think we've got pretty good evidence now.
Yeah, I think for those of you out there who haven't had a URI in the last two years, it hits you in the face again once you get one, right? You've been thankful.
I'll, for this economic audience, tell people that a URI means an upper respiratory tract infection. Well, we all call a cold, but what us doctors call a URI. So.
Sorry, yes. I do think that there's going to be a change in culture with regard to masks, and we'll have to see where it evolves. I do agree that masks and many of our other countermeasures, which are not tenable for the long term, of course, have prevented severe disease, have prevented colds, have prevented flu. And if you talk to pediatricians all of last year, their offices were quiet. If kids don't go to school, they don't get strep. That's not a reason, of course, to keep children from going to school, but there's going to be this balance of the preventive measures that we take, what we as a society can tolerate, what individuals want to do to protect themselves. It's an interesting conversation that we've had about whether we will ever take masks off in clinical settings. I have often thought, I wonder if masks in clinical settings from COVID will be the gloves in clinical settings from HIV, and that whether that is going to be sort of the future of our clinical settings. I do think people will be more inclined to reach for a mask during respiratory season. People may be more inclined to reach for a mask on a crowded subway. I don't think we will, I'd like to not be in a position where we have to mandate these things, but I do think that they will be much more part of the norm than they have been before.
So that was a very helpful response, and we've all learned how to wear masks. So we will look forward to seeing what the new normal is as we go forward. The other end of the spectrum are antivirals. And I think the public's not clear on what the role of the FDA versus the CDC in using antivirals as opposed to vaccine, where we become comfortable with the FDA approving the vaccine and the CDC recommending how it's used for public health. But how do the antivirals work, and what is the CDC's role in that?
So really the CDC's role is more clinical communications around it. So we don't have the similar role with the Advisory Committee on Immunization Practices for Therapeutics as we do for vaccines, just as you noted. So the FDA will authorize a new antiviral like Paxlovid, and the CDC will then work with our clinical partners, will work with societies to update them to provide clinical information for how and when these antivirals should be used. Oftentimes we'll put out an alert to our clinical community so that we can reach the clinical community. Also to know is the NIH in all of this. So the NIH actually puts out the clinical recommendations, clinical treatment guidelines. This is a panel that is very similar to the HIV clinical treatment guidelines panel, but it's a panel of actually many people have served on both panels to take the understanding of what we know about the science and what we know about how the FDA has authorized these vaccines and provide guidance for how they should be used. So that clinical treatment panel lives within the NIH, and then CDC does outreach with our clinical partners. We do outreach with our state and local health departments about how we can sort of get the message out to use them.
Well, that's a very important clarification, because a number of people have been reluctant to use the antivirals because they say there isn't a CDC recommendation about them yet. How do we get the word out for the public to understand in this case it's different than vaccines?
Yeah, it's really important. In fact, we're working on that. We've just have been having some conversations with that, because I think first to know is we now have plenty of Paxlovid. So it's authorized for people over the age of 50. It's authorized for people at risk of severe disease. And we really do want people to use it, not over the age of 50, people at risk of severe disease. Right. And so we want people to know that it's available and know that it can and should be used. And we've just been having conversations about, I think early on there wasn't a lot of it, but we do want people to understand that there's Paxlovid out there now. It's accessible. We have supply. And so if one were to get COVID, to contact, you can go to covid.gov and see where you might get a test and treat. There are many different ways to access Paxlovid through a physician, through a pharmacy. How can you get it? Websites, so that we can make sure that you get it. Certainly, like influenza, it works best if you use it as soon after your diagnosis as possible within the first 5 days. So we're working now, just as you say, to get that message out.
Yeah, because I'm surprised, even at a place like Memorial Sloan Kettering, where we take care of so many immunocompromised individuals because of their cancer treatment, that our docs are reluctant to give it because they don't think it's widely available. How do we get those kind of messages out to the public that there are treatments beyond the vaccine? Not that the vaccine isn't the platform for everything, but that there are other effective treatments that have come on just as rapidly as the vaccines did.
Yeah, I think this is a really important point and something that we're working on with our medical societies. I do think that there has been historically, maybe you can chime in on this as well, this feeling like I'm going to stay in my lane in terms of what I prescribe for my patients. I'm an ID doc, I will do this. You're an oncologist, you will do that. But I do think that COVID has been so widespread that people will go to their cardiologist because that's generally their primary care doc. And cardiologists need to know and understand who can get Paxlovid, and oncologists need to know and understand, and hematologists need to know and understand. And so rather than just speaking to our Infectious Disease Society of America, we need to talk to all the societies, and we're doing that outreach right now so that everybody can be a primary caregiver of Paxlovid and understand the side effects, rare as they are, and drug-drug interactions that they might need to know in order to prescribe this safely.
And Paxlovid is clearly the most effective of the antivirals, but you come from the HIV/AIDS community in your past experience and research. It was combinations of those antivirals that really controlled HIV and continues to control HIV. When will we see combinations of the antivirals?
I think we're going to need to start doing the work on that to understand. Certainly Paxlovid is doing well right now. The early studies demonstrate really good protection from Paxlovid prevention of hospitalization and death. But these viruses are smart. If they can evade our vaccines, they can evade our antivirals. And so has to be the next step. Almost much of what we've seen in HIV, much of what you see in oncology doesn't require one drug. It requires two or three given simultaneously, so you combat all the different ways that a virus might be able to evade your antiviral. And that has to be the next chapter of this. And I know that there's a lot of work ongoing. There's anecdotal studies of people, or not even studies, there's anecdotal, well, this guy is, really high risk and I'm going to do molnupiravir and Paxlovid. We don't have any data to inform that, but we're certainly hearing about the anecdotes.
And I do think your message is important, that all doctors need to be aware of these antivirals, since we're not in a stable situation, as you just told us, around COVID. One very important historical fact about the CDC is you controlled the overuse of penicillin as one of your surveillance activities. And that preserved penicillin as an effective therapy when it was most appropriate. How much of there a risk of overusing things like Paxlovid in the beginning? That's what's keeping doctors other than infectious disease from prescribing it or thinking about it as a protective measure for their patients.
I think you've hit a really important point and a sweet spot we have to hit, but we haven't hit it yet. So one of the big things, maybe I'll put in just a comment on antibiotic and antimicrobial resistance. So if we rewind to 2019, one of the biggest challenges we were worried about was antimicrobial resistance, Candida auris, bad bugs that really we had nothing to combat. Antimicrobial resistance, though it's been out of the news because we've been talking about COVID, I'm worried about is going to demonstrate real concerns. So if you look at what's happened in our hospitals over the last several years, people have come in with fever, respiratory symptoms, ICUs, sick, they get antibiotics. So I don't know about in your hospital, but when I was practicing, we never used more antibiotics than we did during COVID, ever in the history of the hospital. And so that antibiotic resistant challenge, I think, is going to be with us. There was just a piece that was put out in JAMA in the last week or so that demonstrated actually that outpatients for COVID are getting both steroids and antibiotics. They're getting azithromycin, they're getting the antibiotics, a Z-Pak, they're getting the antibiotics you might get for a community-acquired pneumonia, and they're not getting, maybe this was too early for them to be getting a lot of Paxlovid, but they're not getting actually what they need, and they certainly shouldn't be getting azithromycin and steroids as an outpatient. So while I think your initial comment is true, and it's something that we're going to have to be mindful of, I think if you have somebody who has severe disease and a positive COVID test, we need to be reaching for the Paxlovid right now.
Great, thank you very much. Well, as we've just been discussing, communication with the public is complicated with a new evolving virus. Do you foresee a time when the science will be agreed upon and things will be stable and we'll get to a more endemic state? Or how long do you see that will take to get to that level where we're comfortable with our recommendations?
Certainly, I've frequently said that we're going to lead with science, and I continue to believe that. The implication would be that science is black and white, and it certainly isn't. I would like to say there's certain science that we should agree upon that is understood, but that we need to be open to the gray of science because that's how we learn more. And certainly, if we weren't open to how this virus might evolve, how this virus might work differently with our vaccines over time, with our therapeutics over time, then we would have been wrong a lot. And so I think we certainly, we will look to places where science agrees, but it does imply that science isn't moving, and the virus is moving, and we have to have the science that moves with it. For the most part, when we have released a lot of our recommendations, there's a lot of science behind them, and many of them have led to large consensus in 9 out of 10 areas where we've made recommendations, and the 10th, where there's gray, is where people disagree, and that's healthy disagreement. oftentimes when that happens, and you know this very well, that we're relying on preprints, things that haven't gone through peer review, science that is just emerging because we need to make imperfect decisions in imperfect times. And when that happens, usually that scientific dialogue happens at a scientific meeting. And it's robust and it's healthy and it's exactly where it needs to be. That scientific dialogue is now happening on the news. And
Right.
so it's been very interesting to see, and it's our responsibility to try and disentangle that. But it, never have preprints been, pre-publications landed on front pages of the New York Times. And so we're just in a different time of absorbing scientific information. And it's been interesting, and we will have many lessons learned from it.
Well, Rochelle, I want to thank you very much for spending this time with us. It's been very enlightening. We're very privileged to have a physician scientist such as yourself at the head of the CDC, getting us the best possible information as we go forward. And I just want to thank you on behalf of all of us for everything the CDC is doing to keep us safe. And with that, I'll turn it back over to John Williams. Thank you.
Thank you so much.
Well, let me add my thanks to you, Rochelle and Craig, for a really fascinating conversation on a very timely, important set of issues. But that's what the club does, and so it's a great event, and we're looking forward to many events coming up. So my job in the next 1 minute is to highlight some of the great speakers we have lined up over the next few days and on next few weeks. So next week we have 2 signature luncheon events. So those are in-person hybrid events. We'll have Charles Evans, the president of the Chicago Fed, on April 19th. Then on April 20th, we have Brian Deese, the director of the White House National Economic Council. Then we turn to virtual events. We have General Petraeus, former director of the CIA, on April 25th. Jamie Leverton, CEO of Hut 8 Mining Corporation, on May 3rd, and Hugh Frater, CEO of Fannie Mae, on May 10th. And then coming back to our signature luncheon hybrid events, May 16th, we have John Rogers, Chair and co-CEO of Ariel Investments. And then on June 7th, we have Arvind Krishna, the Chair and CEO of IBM. So I'd like to take a moment to recognize our 345 members of the Centennial Society who are joining us today, as their contributions continue to be the financial backbone of support for the club and help us and enable us to offer our wonderful, diverse programming now and in the future. So enjoy the rest of your day. Stay safe.